Good evening, everyone. This is Dr. Vijayan from Aspirant Desk. This is actually a demo session for upcoming INI SS 2024 April session in surgical gastroenterology. And straight away, we will go into the topic. Creeping resection is used in. This was a question asked in 2021 INI SS. The options are mucinous cystic neoplasm, pancreatic neuroendocrine tumor, IPMN, and hydatidosis. This is a straightforward question. We could answer it directly. The answer is C, IPMN. So we are going to see the most important points of IPMN. Males and females are equally affected. 6th to 7th decade age group is most commonly affected. And head of the pancreas is the most common site. So head of the pancreas is the most common site for IPMN, and body and tail is the most common site for mucinous cystic neoplasm, and serous cystic neoplasm and pseudocyst are evenly distributed throughout the parenchymal of pancreas. And three subtypes of IPMN are branch duct IPMN, main duct IPMN, and mixed type of IPMN. In mixed type of IPMN, branch duct IPMN extending into the main duct. Main duct IPMN, the criteria is the dilatation of main pancreatic duct more than 5 millimeter without any obvious obstructive etiology. And the clinical presentation of a patient with IPMN is abdomen pain, acute pancreatitis. So next line of investigation is imaging. So CECT abdomen, MRCP, which is showing the cluster of grapes appearance in case of branch duct IPMN, and ARCP, which is showing the fish mouth appearance of patulous ampulla with the mucin oozing out. Now we are going to see about the imaging slides. This is the imaging which is showing the serous cystic neoplasm, because this is a classical appearance of serous cystic neoplasm. Starburst calcification. Okay. So this is the cluster of grapes appearance. So multiple microcyst. This is a case of serous cystic neoplasm. This is the mucinous cystic neoplasm, huge unilocular cyst, and here we could see the two cystic lesions. This is the mucinous cystic neoplasm, and this is the endoscopic view, which is showing the patulous ampulla with the oozing out of mucin. It's a case of IPM, intraductal papillary mucinous neoplasm. And next is a very, very, very important table, worrisome and high-risk features. Definitely, indirectly or directly, they will ask these features in the question. They can ask directly which of the following is not the high-risk feature. Otherwise, they could ask with a clinical scenario and patient presents with this kind of high-risk features. What is the next line of investigation? That is obvious. High-risk features are present. That is a more prone for invasive malignancy. So definitely the surgical management without any doubt. So for that, we should know, we should be very much thorough about these high-risk features. So 3 are the jaundice, main duct more than 1 centimeter, and enhancing mural nodule more than 5 millimeter. These 3 points we should be very much thorough. Then we could eliminate other options. Okay, so jaundice, main duct more than 1 centimeter, enhancing mural nodule more than 5 millimeter. Okay, so the others are worrisome features like main duct 5 to 9 mm, or mural nodule less than 5 mm, or cyst wall is thickened and enhancing, branch duct IPM more than 3 centimeter, or lymphadenopathy, pancreatitis, CA99 elevated, cyst growth over 2 years more than 5 mm, or caliber change, abrupt caliber change in main duct with upstream atrophy. These are the worrisome features. Okay, this table column we should be thorough. And next thing is cyst fluid analysis. So then they will go ahead with the endo ultrasound guided cyst fluid analysis for cytology to look for in malignant cells, and CEA level in cyst fluid. Cutoff is 192 nanogram per ml, and amylase level which is usually high in IPMN, and mucin is high in IPMN. I just want to highlight 2 points from Shackelford and Blumgott. Shackelford, they mentioned in cyst fluid analysis, when CA levels are less than 5 nanogram per ml in cyst fluid, mucinous neoplasms can essentially be excluded, okay, without any doubt. The one more thing which I want to mention here is pancreatic cyst fluid glucose levels. That is also a potential biomarker for mucinous pancreatic cyst with improved efficiency. That was mentioned in Blumgart. The other points are genetic analysis of fluid is not proved to be effective. It's not proved to be effective to predict the malignancy, which is mentioned in Sebastian. The next point is recent research is showing high concentration of mucin 2 and 4 in cyst fluid indicates the patient is having high risk IPMN, that is with high grade dysplasia or invasive malignancy. That is another point which is mentioned in Shackelford. Next point is genetic mutations. GNAS mutation is the most common mutation in IPMN, around 66%, which is mostly associated with colloid type of malignancy. So CG, computer graphics. So GNAS associated with the colloid type of malignancy, that is mentioned in Blumgart. And KRAS mutation usually associated with the tubular type of carcinoma. So most common genetic mutation is GNAS, okay. Next point is the risk of invasive malignancy in branch duct IPMN is 10 to 15%, and in main duct IPMN it is around 30 to 50%. And genetic mutation for malignant transformation is P53, KRAS, mucin, the other things which we previously discussed. GNAS mutation. There's so many mutations out there. And this is a algorithm for the management of branch duct IPMN. Okay. So first thing we should see is whether there is any high-risk features or there. If there are high-risk features, jaundice, viral nodule more than 5 mm or ductus, main ductus more than 1 centimeter, directly we could consider surgery. If there is no high-risk features, then we should go ahead with the worrisome features. The other points, lymphadenopathy, increased CA19-9, cyst growth more than 5 mm per 2 years, all these worrisome features. If there is no worrisome features, then go ahead with the size of the cyst. Okay. If there are worrisome features, then go ahead with the endo ultrasound. So again, endo ultrasound will look for the definite mural nodule or main duct features suspicious for involvement or cytology suspicious or positive for malignancy. If endo ultrasound showing these features, then go ahead with surgery. If there is no features present in the endo ultrasound, then or inconclusive in endo ultrasound, then the next thing is the last resort is the size of the cyst. Okay, 2 centimeter is a cutoff. If more than 2 centimeter, 2 to 3 centimeter, 3 centimeter, consider surgery in young fit patients. More than 3 centimeter, no doubt, strongly consider surgery in young fit patients. But less than 2 centimeter, less than 1 centimeter, CT MRI for 6 months, then every 2 years, if no change in size. 1 to 2 centimeters is the size. CTMRI 6 months for 1 year, then yearly for 2 years. Then lengthen the interval up to 2 years if no change. Okay, this is a management algorithm for branch duct IPM. The next thing is if branch duct IPMN is diagnosed, we should go ahead with the resection of the diseased segment. Okay, rather than going for the surveillance. What we previously discussed, based on that algorithm, branch duct IPMN resect the diseased segment. In case of main duct IPMN, if actual recent guidelines are telling it as if main duct IPMN, the chances of malignancy or invasive tumor is high. So strongly we should consider surgery. If there are high risk features, size is more than 1 centimeter, then we should definitely go ahead with surgery without any doubt. The surgery is right side pancreatectomy plus frozen section from the distal margin to look for the margin status. And as per the 2017 IAP guidelines, if margin shows, frozen section margin shows low grade dysplasia, better leave without proceeding further resection. Okay, because the progression of low grade dysplasia is very minimal. So that's why, as per 2017 IAP guidelines, we should not go ahead with the resection further. The margin shows low grade dysplasia. So we can repeat margin status twice intraoperatively if persistent positive margins are there. Otherwise, straight away we should go ahead with the total pancreatectomy. So two frozen section margins are positive, showing high grade dysplasia or invasive tumor. go ahead with the total pancreatectomy. So without any doubt, that is the creeping resection. That is otherwise called a creeping resection. If margin negative also, the surveillance is needed, mandatory, because skip lesions, discontinuous lesions is possible in the remaining duct, remaining parenchyma. So decreased survival is associated with the tubular subtype, lymph node metastasis, vascular invasion, positive margin. Other three things we are very much confident: lymph node metastasis, vascular invasion, positive margin. Then the survival should be decreased. The one more thing which we should memorize is a tubular subtype. So tubular subtype is having decreased survival. So even the IPM and records, we could go ahead with the resection further. So that's what mentioned in Shackelford. So continual survival benefit with further resection is there, even IPM and records. So this is the most important tabular column for NEET SS and INI SS everything, okay, which is mentioned in Sabiston. So for IPMN, I already mentioned females and males are equally affected. 60 to 70 years of age group is affected. That is the most common site. And appearance in image is poorly demarcated, lobulated, polycystic mass with the dilatation of main or branch duct. So communication with the duct is present, obviously. Ancestor fluid analysis cytology showing the tall columnar mucin containing cells, and mucin stain is positive, amylase should be high, and CA should be high. The cutoff is 192 nanogram per ml. The other things are pseudocyst, serous cystic neoplasm, and mucinous cystic neoplasm. Serous cystic neoplasm, central starburst calcification, and mucinous cystic neoplasm, axil calcification. Okay. So this is the end of the session. So please get registered for our live session of high yield topics going to happen next month without fail. And cost is around rupees 3,500 plus GST. Weekly 3+ sessions will be conducted online, and WhatsApp MCQ discussion will be happening. And at last, based on the analysis of previous year papers, GI trauma and pancreas anatomy is a most favorite topic of examiners. Definitely, they are asking one colonic trauma, colonic injury, pancreatic trauma, and one more thing is duodenal hematoma. These three questions were asked in last year April INSS. So we are analyzing previous year papers, and we are gathering all high yield topics to give you the plus points for the last minute revision and for your refreshing your preparation. Okay. So without any fail, register and get benefited from our live session. And last thing is, what is Hamodi tumor? Whether it is aggressive or indolent. So if you know the answer, please mention it in our WhatsApp group. Thank you, and all the very best from Aspirant Desk. Thank you.